Morning. Okay. Good morning. I'm Dr. Jay Griffith, professor in the Department of Psychiatry at ETSU. And it's my pleasure to introduce today's speaker, Dr. Barton Evans. Dr. Evans currently practices clinical and forensic psychology in Asheville, North Carolina, and has held the position of professor in the Department of Psychiatry at George Washington University since 2000. His training is extensive and includes a Ph.D. in clinical psychology from American University, completion of the advanced psychotherapy program at the Washington School of Psychiatry, and postdoctoral training at Yale University School of Medicine. His professional accomplishments are numerous, and I need to abridge them for the purposes of the presentation. He publishes several peer-reviewed manuscripts yearly, has greater than 150 workshop and paper presentations, and has authored 2 books and is currently completing 2 books in forensic psychology. I have worked with Dr. Evans in the past and have heard him speak on complex psychiatric disorders, and I believe that we're in for a treat. The title of the presentation is Seeing the Person in Personality Disorders. Please welcome Dr. Evans.
No. Can you hear me now? Okay. Sometimes my voice trails off a little bit, so if it does make movements and things like that, and just let me know. Okay. So let me go back here. So this is called Seeing the Person in Personality Disorders. What I'm going to try to do today is to take a look at the concept of personality disorder and try to flip it on its head a little bit and look at it from a kind of a different perspective. But I'd like to give us a little background so that we can think together about it. And I'm going to end the day with 2 cases that I'd like us to think about. So here are the disclaimers. And okay. So first of all, what do I mean by seeing the person in personality disorders? Why is knowing about personality disorders important? And why start with the person, the personality, and then the personality disorders, which is a kind of a different way than we look at things from a DSM perspective. It really, I think, supplements it a lot. And by seeing the person, we want to try to step back and take a look at the person in their totality and not just their disorder. And so let's talk a little bit about personality. Personality characteristics are characteristic patterns you're thinking, feeling, and behaving. And it's about understanding individual differences, the difference in your personality and mine and the person sitting next to you, but also understanding how the various parts of the person fit together as a whole. So we're looking at a kind of comprehensive way that a person integrates thinking, feeling, and behaving within their characteristic patterns of living. And so, we're kind of talking about what's a normal personality. Anybody come up with an answer for that? Is it the average person? And what's an average person? And can being average be dysfunctional? That's a question. Is it meaning free from mental disorder or well-adjusted? Is it like just like me? That's one I see the most in training, is we think normal is who we are. And I don't know about you, but that can get in some shaky ground pretty quickly. And I want to talk a little bit about personalities and disorders from a sign versus a continuum-based model. A sign model means you see a set of signs and then you're able to label something. A continuum is to take a look at a particular characteristic of personality, going all the way from highly functional, maybe above average in function, to troubled function. And so let's talk a little bit about some of the conceptual roots about the formulation of mental disorder, or what I call problems of living. I'm very influenced by interpersonal psychodynamic theory, Harry Stack Sullivan. So this is the father of classical descriptive psychiatry. This is Emil Kraepelin, and he was, his model was widely regarded as the oldest trend, and it really kind of borrows from the development of medicine in that period of time, where you were looking at fixed medical entities of biological and genetic origin. Mentally ill can be clearly differentiated from normal individuals. Let's get back to normal again. And you can have an objective identification of a disease. Okay, and the Kraepelinian model focuses on careful description of symptoms grouped within a clinical syndrome, research following the syndrome's course over time. We see that in a lot of the DSM-5 these days, noting which factors are accompanied with the syndrome, the frequency, distribution, and heredity, as well as phenomenological and cognitive manifestations. And the endpoint of this research is a clear, definable taxonomy of mental disorders. It's very much like medicine, and like disorders of the body. How many people are familiar with Harry Stack Sullivan in any way whatsoever? Okay, not a lot. Okay, so Sullivan was a psychiatrist in the 30s and 40s in the Washington area. He redefined psychiatry as the science of interpersonal living. And he began to think about personality as manifest in interpersonal situations and not otherwise. That in other words, to understand human beings, you have to understand them in their context. So these are two fairly distinct models of thinking, and they're both valuable because they offer kind of different ways of thinking about things. Sullivan, with his typical Irish humor, he tended not to like jargon. But he did develop one thing he called the one genus hypothesis, which is that we're more simply human than otherwise, be we happy and successful, contented or detached, miserable or mentally disordered or whatever. So he's really the kind of one of the fathers of the continuum model, that we all are kind of more human than not. It's a matter of degree and kind, as opposed to distinct differences. Okay. I'm just going to run through these slides, and you can read them. The concept of personality disorders goes all the way back to the Greeks, where Theophrastus described 29 different character types, and Galen's concept of personality types, which he tied to the four humors. Then we start seeing kind of the more modern versions of this with Peniel, and called personality disorders, manie sans délire, which is insanity without delusion. And how many people here have diagnosed using the DSM-2 besides me? Okay. So what did we call borderline personality back then? Pseudoneurotic schizophrenia, borderline psychosis, and things like that. There wasn't, DSM-2 had no personality disorders much to speak of, certainly not like we have today. Krafft-Ebing began to look at personality patterns of sadism and masochism. Kraepelin actually had a very interesting, as you would expect, an interesting taxonomy of what he called psychopathic inferiority. And that's going to be interesting to see how those kind of match up with the more modern DSM-3 and beyond concepts. Freud was very interested in the personality, the whole person, and of course he started with the concept of hysteria as a personality adaptive pattern. Jung brought us the traits of introversion and extroversion, which based on research are the most reliable. you can really differentiate people on a continuum of introversion and extroversion quite nicely. Reich, Wilhelm Reich, some people think about Reich as the beginning of personalities, which talked about defensive structures that formed a character armor, which is a kind of a way of dealing with the inner conflicts and troubles in the world through these particular, and the concept I like about that is it's a rigid pattern. It's not a flexible pattern. We need to be flexible to deal with much of life's travails. Then we have Sullivan, who I think is the father of modern personality disorders, and he didn't talk about them as disorders. He called them dynamisms of difficulty, focusing on the dynamic aspect, and that somebody who could have some of these patterns under certain circumstances wouldn't need to express them as much as they would in other circumstances. And he focused a lot on the schizophrenic dynamism, which is probably closer today to what we consider to be borderline personality disorder. He, obsessive and paranoid, and his descriptions still are very, very rich and very useful clinically. And so we have Cleckley with antisocial psychopathic, Menninger with passive-aggressive, and then 1938 we have Adolf Stern, who was the first person that I've been able to find that really wrote specifically about borderline personality disorder. Developed at the Menninger's clinic with Robert Knight's thinking, and then with the publication of Otto Kernberg's book around 1974-75, really brought borderline personality disorder to the fore. And John Rush, who a psychiatrist who was into understanding of depression and cognitive treatment for depression, called this one of the great accomplishments in psychiatry because it moved a whole group of patients out of a category which we consider to be hopeless to one where there's some kind of dynamic capacity to work with the person. Fairburn wrote beautifully about schizoid personality, and of course Kohut on narcissistic personality disorder. But in terms of modern taxonomy, the person that we really want to think about is Theodore Millan, who passed away in the last year. Quite a brilliant thinking, and was really interested in biopsychosocial patterns. Millan is kind of the architect. He was the thinker, the head of that group, study group for the DSM-3, which was unusual because he's a psychologist, and it was very unusual to have a psychologist be so involved. And it becomes, he begins to look at things as chronic, recurrent, enduring biopsychosocial patterns that occur across a variety of contexts. In other words, your adaptive capacity doesn't have a flexible quality to it. And the important thing that he talked about is in understanding acts, in the old way of thinking about things in the way I still think, axis 1, where you have more symptomatic presentations, it can help you understand why people who have chronic symptoms of depression and anxiety may have trouble being able to resolve those, or they come up over and over again. It may be less due to the pure kind of depressive or anxiety symptom presentation, but more an expression of these enduring patterns. And so he was a beginning person to say, let's look at the person as well as the symptoms. And I think this is a very important contribution to the DSM. And here are a bunch of his early personality disorders. I'm just going to run through this real quickly. And so currently the DSM, when we talk about personality disorders, it's an enduring pattern of that is inflexible and pervasive across a broad range of personal and social situations, pretty much what Millan developed in the DSM-3. It leads to clinically significant distress or impairment. So if somebody has severe, what we would consider obsessive compulsive personality, but it isn't, as an interesting thing, if it's pretty much egocentric, it's not uncomfortable for them, it doesn't cause them distress, it doesn't cause them trouble. there's a kind of a question of whether we would diagnose it using the C criteria. And it has to be stable and of long duration and traced back to at least adolescence or early adulthood. So that criteria really looks at the kind of the duration of the symptom across time. It's not accounted for by other. I'm sure you all know this, so I'm just going to let you read it. Under DSM 3, 4, and 5, if we have somebody that's under 18 years old, they kind of recommend that you don't use a personality disorder diagnosis. It's an interesting concept. It talks about some of the flexibility in the storm and drang of adolescence, and that might get resolved. And okay. So now we kind of covered that. Let's just start. I don't know if people have read this, seen the slides already. If you have, don't give it away. How frequent? So your own experience. How frequently do you diagnose personality disorder among your clients? Let's work with percentages. How many people think it's about 10% of the time? Okay? How many people think it's less? How many people think it's more? Yeah, okay. And a third? Anybody think a third or higher? Okay. Anybody go for 45%? Yeah, okay. Okay, so let's take a look at the research. We have our own impression, but let's take a look at the major studies of this. The first one was a study done at Yale with Kathleen Marikangas and Myrna Wiseman, who is one of the founders of interpersonal therapy for depression with Gerald Klerman. And they did a study in which they, and Marikangas is an epidemiologist, and Wiseman is both a psychiatrist and epidemiologist, and are both really smart people. And they found that kind of 1 in 10 individuals and nearly half of the psychiatric population, okay? And so the chance of you having a patient with a personality disorder, according to their research, is about 50%. That's on the high end of what we were talking about here. But that's an old study, 1986. There's some methodological issues. Yes? What they were doing is they were surveying in the outpatient Yale mental health clinic, Connecticut mental health clinic, and then around in the community, because they had a lot of community-oriented work. It's one of the homes of epidemiological research. So it's New Haven, and the environs, the broader area. And you could argue, it's New Haven, of course, but and you could also argue that because back then there was pretty strong psychoanalytic orientation still at Yale, and you could say, well, maybe these people are psychoanalytic and they're doing stuff. So, but let's take a look. And so the national in 2004, the epidemiological survey on alcohol and related disorders found that 15% of Americans had at least one personality disorder. These are the most prevalent ones. Now, this is a straight-out epidemiological study with broad sampling, and it's a United States sampling from a national survey. So we're starting to see kind of some parallels with the Yale group and with a national survey. The risk of avoidant, dependent, and paranoid personality is more significant with women than men, and antisocial disorder is more with men than women. And so let's go cross-culturally, and Norwegian studies indicate about 13.4% of adults are still kind of in that zone. And personality disorders are more frequent among single individuals from lower socioeconomic classes. Would we say that, wouldn't we kind of expect that anyway? Because if somebody has a pervasive personality disorder, it may be they have trouble with getting relationships and have trouble with work. And so that's kind of a bidirectional sort of finding. Great Britain, 4.4%, a pretty limited sample, and again, highest among men who are separated unemployed in urban areas, higher use of healthcare services. Cluster B was associated with early institutional care and criminality, which is kind of interesting. But this is this study, I'm bringing it up because it's the one outlier of the four. But now we get to, are people familiar with the big, the Midas research direction? This is out of Brown University, Psychiatry Department. This is a very well-funded, well-researched, kind of multi-directional to kind of take a look at incidence of mental disorders in clinical practice. And so this is a pretty nice sample, 859. For a psychiatric sample, that's actually pretty good. And they were diagnosed, they were administered, instead of asking somebody, did you have this disorder? Yeah, it's in the chart. This is actually a proactive study where they came in and they took those 859 clients and they gave them the SCID for DSM-4, the SCID-2 personality. People are familiar with the SCID. Great, pretty good instrument. Great way to learn how to diagnose, in my opinion. And there's a new one for 5 coming out. It's supposed to be out, but I went on the website yesterday and it's not out yet. So the next month or two, keep looking. And this is the first epidemiological study, clinical epidemiological study, using structured interviews. This is a really quality study, high-end, focusing on clinical samples, not epidemiological in the community. And so a third of the clients using this method were diagnosed with one of the 10 official DSM-4, which are same as the DSM-5, so 31%. But if you included personality disorder NOS, where that didn't quite meet the criteria for one of the 10, but it had enough traits when put together that it met SCID criteria for personality disorder NOS, it rises to about 50%. So even with the higher, with the better research, we start to find that Marikangas and Wiseman pretty much nailed it back in '86. So, and interestingly, is when we think about the kind of Kraepelinian model of sort of getting disorders separated, the majority of people meeting criteria for one specific personality disorder were diagnosed with more than one. So there's some symptom diagnostic overlap, which we kind of expect because we're looking at personality, and personalities don't, and their disorders don't cluster up so neatly. The avoidant, borderline, and obsessive personality disorder were the most specific, and their personality disorders as a group are among the most frequent disorders treated by psychiatrists. So the idea that it's like 1 in 10 is actually doesn't hold up in terms of what we know in terms of the current research. So this is an important topic that we're as likely, flip a coin, the next patient you see is likely to be able to code for personality disorders. We often don't, because it's a little more complicated. So the takeaway message is that the modern practice of focusing primarily on what was formerly known as Axis 1 is incomplete, and the failure to consider personality disorders can hinder long-term treatment success. And I also think I do forensic work, and then can also hinder an accurate picture of the person in the psycholegal situation. We see this at the VA. very rare to see a personality diagnosis in the records in the VA. Very, very rare. And yet, in my experience, it kind of is like this, maybe even a little bit higher for people coming in for disability exams. How are we doing? All right. So now I'm going to start with the person and talk a little bit. How many people are familiar with the psychodynamic diagnostic manual? As I would expect, okay? Not a lot, okay? This, the DSM starts with current symptoms, which we currently considered Axis 1, and then moves to Axis 2 secondarily. And I'm showing my bias, call that a surface diagnosis. The PDM, I'm going to use PDM, starts with personality patterns and mental functioning, and then how symptoms become an individualized expression of the person, and which I would call a depth model. And it has a very strong research foundation leading to evidence-based treatment. For those of you who think that psychodynamic therapy does not have an evidence base, it's important to read the literature on that, because there's big meta-analytic studies showing that psychodynamic approaches actually work, and they actually work with some clients better than others, and one can think about that in a particular way. And with personality disorders, it may be one of your preferred treatments. You know, we have good research and good backing in cognitive behavioral therapy with, but we also have very good research showing psychodynamic-oriented approaches can be very, very useful, particularly with borderline personality disorder. And so the way that the multi-axial system works with the PDM is that we start with the personality pattern and the disorder. We then move into a profile of mental functioning, and then into the subjective experience of the client, which is then, they call, that's the symptom patterns. So you're starting with the person, their disorder, how that personality is put together in terms of mental functioning, and then how that expresses as symptoms. And as you can see, this might be a nice kind of counterpoint to modern diagnosis of personality disorders. And, you know, being in their pretty inclusive or perhaps over-inclusive way, they've come up with all of these patterns of mental functioning: affect regulation, capacity for relationships, internal experience, affective experience, defensive patterns, capacity to form inner representations, the kind of way, an inner representation from psychodynamic theory is the way you think about the other person. So an internal object representation of somebody that's paranoid is that you see other people trying to hurt you. Capacity for differentiation and integration, the degree to which a person becomes a sort of extension of the self, or to the degree to which a person is able to recognize the other as somebody different with distinct needs and interests than our own. Self-observing capacities, internal standards and morality, and then basic mental functions, flexibility of character formation, and age-appropriate mental capacities. The S-axis is essentially comparable to the axis 1. And in the PDM, what we do is we start with the person, their mental functioning, then we look at symptoms patterns as disorders that impact the overall functioning. If you have somebody that has, I like borderline personality disorder, I've done a lot of work in that area over the years. If you have somebody that is so pervasively depressed and anxious to the point of panic, and you don't intervene with that, what's the likelihood that all the talk therapy in the world is going to be helpful? It's my experience. I mean, I just remember when Prozac came in, it was like, oh my gosh, it cut off a year of therapy. And back then I was working with people 2 and 3 times a week in intensive psychotherapy. That's a while ago. And clearly the capacity to use mood stabilizing drugs and SSRIs that manage both anxiety and depressive symptoms, and abandonment fears and rejection sensitivity and things like that, that wonderful cluster of things, actually can help a person be more regulated and go into their therapy in a deeper way. Okay, so we're going to step back into, how many people are familiar with Kernberg? Heard the name, okay? How many people have ever read his basic book? It's an old book, okay, yeah. Old guys raising their hands generally. What's that? Old enough. It's important about illusion, Jay. So, Kernberg offers a very interesting way of looking at things. Not only are we looking at the patterns in the personality structure, we're looking at the way in which the personality is organized. And he comes, and a structure might be that you have an histrionic kind of style, you may have a narcissistic style, you may, and in this model there's no borderline personality disorder, okay? It's just a kind of a, but what we look at is the degree to which that, is organized at a variety of different levels, neurotic, borderline, and psychotic. And so we could have a narcissistic personality style that was organized at a borderline level of functioning. And I'm going to go over those very quickly with you to show you some of the difference, but you could have somebody who has a narcissistic style that's organized at a neurotic level or at a psychotic level. So the neurotic level, we would have intact reality testing, consistent sense of self and others, good sense of one's strengths and weaknesses, sense of value, ability to commit in relationships, and stable identity with life goals, cope with stress generally adaptively, and rely on mature defense mechanisms when stressed. Borderline, reality testing and logical thinking are generally accurate but very vulnerable to stress. And so a person, you have these examples of people who are functioning in very high jobs, but they get into very stressful situations, and all of a sudden the reality testing just kind of falls through. A fragmented sense of self or others. Splitting is used defensively into all good or all bad. Sense of self and others. Chronic relationship problems with commitment difficulties. Unstable identity. And then affective dysregulation and impaired coping under stress, and a reliance on more primitive defenses, primarily splitting as a defense. And then, of course, at the psychotic level, we have somebody that has severely compromised reality testing with thought disorder and perhaps even hallucinations and delusions, vulnerable to cognitive perceptual disruptions, inconsistent, chaotic sense of self and others, severe relational disruption, often infused with a sense of terror. Boundary problems between self and others are blurred, having trouble knowing whose thoughts are where. So we get into symptoms like thought insertion and things like that. And pretty profound impairment in occupational and social functioning, and use of primitive and regressive defenses that severely impact stress tolerance when there's difficulty. And so what he's trying to say is we have a person, we have their particular style, and then we have a level of organization. This allows for a kind of rich diagnostic discernment that allows you to kind of think about things in a kind of multi-dimensional sort of way. And so, again, it's personality patterns and symptoms. Personality disorders are then organized at one of the three levels. Okay. And so the PDM has a variety of more personality styles and disorders than the DSM. And I'm just going to kind of whip through this. I think my slides are available to you, so you know. And when we start to get into psychopathic, we get into difference. One of the things I love about this is we have in narcissistic personality disorder, we have the arrogant entitled, which is more the DSM, but we often know about people who are depressed and depleted narcissistically. They have tremendous narcissistic wounds. They really present in quite a different way than what we see in the DSM, and yet the core issues around a damaged sense of self are maintained. Sadistic and sadomasochistic, depressive personality disorder. I kind of like that. We kind of pick that up in the DSM-5 under persistent personality disorder, but it begins to take a look at the structure of the personality that leads to chronic, why is that person having persistent depression over and over again, even if they've had intervention and things like that? Is there something in the way that they do business in their life that really causes them to repetitively have depressive experiences that if we dealt with the pattern, then that would, in the long term, help mitigate the frequency of depressive experiences. Dependent personality disorder, phobic, anxious personality disorder. So looking again like depressive personality, somebody who's chronically anxious. Now where do we pick that up in the DSM? On Axis 1, we call that generalized anxiety disorder. It's seen as an anxiety disorder with a focus on symptoms, but it may be that there's a way in which the person sees themselves in relationship to others that's chronically creating a sense of anxiety, and that we want to take a look at the person and the pattern as well as the symptoms. Have histrionic or hysterical, dissociative personality disorder. I like that, as a concept because what we know from the research, and this is a controversial diagnosis. I think that the research supports it, but it's not as frequent as some people might say. But it is a kind of pervasive adaptation to severe childhood abuse, usually sadistic before the age of 12. That's what kind of the research shows on this. And so it really is probably thought better as a personality pattern than as symptom presentation. And so along each of the personality styles, we take a look at the different kind of maturational patterns, central tension, central affects, pathological beliefs about self and others, and then central defenses. So what you see in this particular model, that might be a nice complement to what you're doing in the DSM. We're seeing, if you're interested in personality disorders, this is a way of kind of getting into the complex inner world, which is often, I don't know what your experience is, always the most challenging clients that I've ever worked with. And it requires more than just symptom reduction. Okay, here's an example of depressive. The pattern is probably a genetic predisposition with the depressive style. The central tension is goodness or badness, or aloneness or relatedness. Sadness, guilt, and shame are the central affects. Pathological belief about the self is something bad or incomplete about me. Pathological belief about others. If people get to know me, they will reject me. Defenses are interjection, reversal, idealization of others, and devaluation of self. And for those people who are really interested in this, there is a wonderful assessment tool that is based not on a report of the client, but actually after, I think, 5 sessions with a therapist or using a specific interview, you can go online and do a Q-sort. I know people are familiar with a Q-sort. You get a description and you kind of check about, is that really a prominent characteristic or is it not really at all characteristic? And you kind of go through, I think it's about 200. The swap is about 200. And that it has a lot of empirical foundation and validity to it, and reliability. And it's computer scored, and it's a quick way, I think, to get into some of the complexity of this. And clinicians can really reliably begin to use it. So it's 6 sessions of contact or an interview. Good inter-rater reliability above 0.8. That's actually pretty good. That's better than a number of the diagnoses in the DSM. And then retest reliability over 4 to 6 months, as you'd expect with a personality disorder, is 0.9. Those are very impressive. I don't know if any of your stats geeks, but those are impressive numbers. And high convergent validity with a wide range of external criteria and 100 peer-reviewed articles supporting it. That's pretty good science. Okay. I'm right on time, my gosh. Should we all have a collective breath here as I kind of march through this? Yes.
Because this is recorded.
Is that a measure that you would use with all of your patients, or just if you're getting the sort of flavor that they might have a personality disorder?
It kind of depends on your patients. When I was doing psychotherapy, back before I became a forensic psychologist, it was back before the invention of fire and the wheels. But back in the late 70s, early 80s, most of my clients I saw were, I would call in the range of severe personality disorder. I would use a swap all the time. But it's a nice instrument. If you're seeing, well, you could argue since 50% of your clients are going to be that, okay? But you can, if you were working in psychotherapy and with a group of people where there was a high frequency of personality disorders, then it could be an instrument that you used quite regularly. It doesn't take that long after about 6 sessions. It works pretty reliably. And there are 200 items that you're coding on a 1 to 7 scale, and on the computer going, boop, read, boop. So it's actually a pretty good instrument. I love it. I just think it's fabulous. Did that answer your question? You bet. So it would be sort of depending on your kind of clinical. Any other questions to this point? Yes. We have this gentleman who's running over. Wants you recorded for posterity.
How does it compare to something like the Minnesota multiphasic for personality disorders?
Okay, the question is, what about the MMPI? Okay, I love the MMPI. Okay, it's the 900-pound gorilla of psychological testing. The last I checked, there were about 11,000 citations, 8,000 of which were peer-reviewed articles. So it's a great instrument. It doesn't have any personality disorder scales. Les Morey, who was a fabulous researcher, did the Morey personality disorder scales, but it's not computer scored. You've got to hand score them, and that takes a fair amount of time. And they're kind of okay, but they're not really specifically oriented. Now, Morey went on to develop something called the Personality Assessment Inventory, or PAI, and it picks up some personality disorder elements. It really does go after borderline, and pretty reliably. But Millan, remember Millan back when he had big hair? He developed something called the Millan Clinical Multi-Axial Inventory, which assesses all of the a whole variety of personality disorders. The problem with the Millan is it's 175 items with a lot of shared item pooling, which is psychometrically somewhat problematic. I won't use it in court. And I love that kind of instrument because the science is just a little fuzzy with it. There's a new version of it coming out, and they may have, taken care of some of that. But if you were really in the kind of personality disorder area, the MCMI with the 4th edition coming out, Millan Clinical Multi-Axial Inventory would be really the instrument of choice. It's kind of like a MMPI, it's a self-report test model. Was that helpful? Did that get it? Maybe too much? No, anyway. Yes. The MBHI, I believe, is the Millan Behavioral Health Inventory, which is used a lot in primary care at looking at the overlap between physical symptoms and presentations and psychological difficulties. And I know I haven't used it, but I hear it's a terrific instrument.
Yep. Millan was very interested in the beginnings of behavioral medicine, and I actually had the pleasure of training under him during that period. So we got intense exposure to both the MCMI and the MBHI.
Yes. Which one did you like better? Or did you like
Well,
both?
I was oriented toward the MBHI because my interest was in psychosomatic medicine.
Right. And a pretty good instrument.
Excellent instrument.
So that's, for those of you who are interested in practicing psychiatry and mental health care in that kind of integrated care, and that's really where things are going these days. You know, psychologists and social workers are ending up increasingly in primary care offices. That's a huge particular direction. So that's a great instrument. Kind of keep it in the back of your mind. Yes? Oh.
There is something to be gained in those particularly difficult patients.
One of my 2 books is called The Handbook of Forensic Rorschach Assessment. I'm like, we don't even want to go in. I'm a huge believer in, we've actually changed the name for those. We're calling them performance-based tests. And so and those are, the projective tests are kind of like the Rorschach and the TAT. For kids, there's a Roberts, which is a fabulous apperception test, which is fabulous. There's a wonderful instrument, kind of hard to learn to score, called the Adult Attachment Projective. And these are all, they approach the assessment of personality in a very different way. In a self-report test, what you do is that you read an item and you kind of introspect. And you say, is that like me or is that not like me? Or is it a little bit like me or a lot like me? And that's what you get. Not like the MMPI, the PAI, and the MCMI are self-report inventories. Used to be called objective tests, but there's a problem with the use of that term. Projective tests ask you to respond to a stimuli, which is then behaviorally coded. So when you give the Rorschach, you give a Rorschach response, and you get the response, and then later you come back and elaborate it, and then you score it. And so what you're doing is scoring behavioral systems. Which of those 2 methods do you think is better predictive of behavior? Well, it turns out the projective tests are better predictors of actual behavior than self-report, because self-report's limited by, A, the degree to which you're aware of yourself, and the degree to which you're willing to share it. And those are significant limitations that projective tests don't have. So, no, I love
I think one of the things I like about the projective is that, particularly if you're not clear if there's subtle underlying psychotic features, I think it's wonderful to have projective tests to kind of help differentiate that more than some of the other tests.
Yeah, I mean, I'm preaching to the choir here. I mean, I love them. There's no instrument better than the Rorschach for picking up subtle thought disorder and reality testing signs. Even the critics of the Rorschach will acknowledge that. So, yeah, I love projective tests. Okay, so got 10 minutes, so let's do this case. There are 2 cases. Okay, and just very quickly, this is borderline personality disorder. You have to get 5 out of the 9 to meet criteria for borderline personality. Okay? So if we do combinations and permutations, 5 at 9, there are a lot of different presentations in that. Okay? In PTSD, they did a research under the new criteria, doing all the combinations and permutations to meet criteria. They came up with 250,000 different possible combinations. 250,000. So, anyway. So here we have Jane 1. Jane 1 is a 28-year-old female who's never been in a committed relationship for more than 5 months. She meets with men in bars and after drinking too heavily goes to the man's apartment and has unprotected sex. This is pretty regular. For the next week to a month, she's madly in love with Mr. Wright, but soon becomes disenchanted with and highly critical of him. This is kind of amalgamation of an actual case. Some things changed. Jane is constantly angry with the man, flies into intense rages over feelings that he is cheating on her or stealing from her. These rages pass quickly, and she will act as if nothing happened. During one of her rages, she takes a sharp kitchen knife and cuts the inside of her forearm and then refuses to have it checked medically. She's doing well as a graduate student in clinical psychology, which she initially thought was the only true profession, in quotes, but now is thinking about going to graduate school in public relations because psychology is full of phonies. Okay? So you get a picture of this person? Are you happy when this person walks in your door? Maybe not. This is a tough client. This is a very tough client. This is not somebody that's going to work out in 10 sessions. Jane 2, is a 28-year-old female who married her husband at the age of 21 after 4 months of a whirlwind relationship, feeling that she met Mr. Right and that she would never have to feel lonely again. Soon after their marriage, she became aware that her husband, who was all roses and flowers and a complete gentleman during their courtship, now flies into rages if the house was out of order, if she prepared meals improperly. Although she works full-time as a major financial provider and her husband is chronically in between jobs, she characterizes him as totally a great guy who has a lot on his mind, and if she was just a more caring person, there wouldn't be these problems. Believable? This is actually the case. Jane, too, comes to therapy for depression, sharing that she feels empty all the time. Her despair is most intense when her husband goes away for many of his fishing and hunting trips. She admits to overwhelming feelings of jealousy and fears that he's having an affair. She feels intensely ashamed of her mistrust. During these times, she takes a sharp kitchen knife and cuts herself only enough to bleed, and then tells her husband that she scratched herself working around the house. You got a picture of this person? Seem realistic to you? Okay. All right. So, let's take a look at the DSM. Jane 1. Unstable, intense interpersonal relationships alternating between extremes of idealization and devaluation. Intense identity disturbance, unstable sense of self, impulsivity in at least 2 areas in terms of substance abuse, sexual acting out, recurrent suicidal behavior, gestures of threat, or self-mutilating behavior. Pretty strongly meets this. Affective instability due to marked reactivity of mood, episodically irritable or anxious lasting a few hours but rarely more than a few days. And then inappropriate, intense anger or difficulty controlling anger. Is Jane 1 a card-carrying borderline personality disorder according to DSM? Absolutely. Absolutely. Jane 2, frantic efforts. Frantic efforts to avoid real and imagined abandonment. Unstable and intense interpersonal relationships with extremes of devaluation and idealization, recurrent suicidal gestures or self-mutilation, affective instability. In her case, intense episodic dysphoria and chronic feelings of emptiness. Does she meet criteria? Did Jane 1 and 2 have the same clinical presentation? They both easily code for borderline personality disorder. But Jane 1 is more of a kind of narcissistic personality disorder with an arrogant entitled type, and I'm using the PDM. And Jane is more depressive personality analytic type. They're both organized at a borderline level. Are they going to have different transference and countertransference issues? in the course of treatment, they're going to be really quite different. And so what I'm trying to say, does the same treatment work for both cases? And medication, would you use the same medications in both cases? Would you refer to a therapist that you don't like? That's not uncommon, actually. I don't mean to be, but these clients bring out very powerful countertransference reactions around saving versus really disliking. Winnicott had a wonderful paper called Hate and the Countertransference. That's a brilliant paper about how the kind of feelings that get stirred up in therapists. So what the takeaway message, okay, I'll do that. Takeaway message is the DSM has a certain ability to help us understand. But if we're really interested in this kind of client, and we're really interested in looking at the person before the personality disorder, there's some significant advantages to also learning the PDM. Yes.
One of the reasons that I really like to think about Gunderson's ideas in terms of psychotic borderline, borderline syndrome, as if borderline, and neurotic borderline, is in this situation, I would see gene 1 as kind of in that interface between psychotic and borderline syndrome, and at that level of maturity, I'd see gene 2 as much more in the neurotic borderline range.
Right.
And I would use those characterizations in answering the questions that you posed about both psychotherapy and medication choice.
Right.
I'd be much more concerned about gene easily deteriorating into psychotic functioning readily. And I think that one of the problems with using that, and I might ask you to comment on this idea, with DSM and the entire idea of going away from theoretical components, the thing we lose is, you know, for instance, the definition of neurosis, I think, is critical to understanding human behavior. It's one thing to have a core conflict. It's another thing to use paradoxical behavior to respond to it instead of goal-directed behavior. People have almost lost track of that. At the same time, we've lost track of how important defense mechanisms are to the nature of what character is. And all of those are kind of things that have been sacrificed in DSM to this atheoretical model, but I think they're critical to understanding how personality function actually occurs in individuals such as this.
You pretty much summarized what I was trying to get in the session. I totally agree with you. One of the things that we can think about is that we can have both. It's not one or the other. That certain of these models have some diagnostic clarity. I mean, the reason that those 9 characteristics are put in the DSM is because, following the Kraepelinian model, there's been research that indicates that reliably differentiates the group from another group. And that gets us to a certain point. But then when we're really thinking about, on-the-ground treatment of a person, looking at defenses, looking at character formation, looking at levels of organization, and I love James Gunderson's work on that. I think he's the most brilliant person who has, his work at McLean has really demonstrated that borderline personality disorder can be treated. But it takes about 4 or 5 years of intensive work with highly trained therapists. But people can come out the other end either significantly improved or really not meeting criteria for the disorder. And he's the one that brought us that research. To me, back when you're a DSM-2 guy as well, we had neurosis and psychosis. We didn't have borderline. Borderline really helps us a lot in terms of functioning. So these 2 models, I think, can be used quite complementarily. And I'm a big fan of teaching this, and it's kind of coming around because, psychoanalysis kind of got rejected And for not entirely the wrong reasons, but what's happened is that as the people in the psychodynamic therapy area have begun to do more research, you're beginning to see a more research-based formulation that where ideas of neurotic, borderline, and psychotic really start having some empirical foundation.
I may have mischaracterized it a bit. I've been taught and trained a lot with DSM-2. I'm not sure I ever used it for diagnosing, actually. But, for instance, the idea of superego neurosis, which is a DSM-2 kind of idea, without that understanding, focusing the treatment plan for Jane 2 is very difficult.
Absolutely. Absolutely. So, right on time, so here's my takeaway message. And this is kind of goes off a little bit, around a little bit of theory of what psychotherapy is about, particularly with these clients, which is that the task of the client is to see and let go of defenses that hurt her, to face rather than avoid what makes her anxious and afraid, and experience warded off feelings as deeply as possible. The task of the therapist is to point out rather than to avoid defenses, help a client face what she fears, and help her feel her feelings as deeply as possible. And persisting in the face of clients' defenses is a form, in my opinion, is a form of love. Okay. Thank you very much.
Barton, I realize this isn't the focus of your talk, but I wonder if you might just share with us some thoughts about how one goes about developing the awareness of countertransference in response to the patient's activities.
Okay, so the question, I think you heard all the question, how do you develop an awareness of the concept of countertransference? I can tell you how I've done it and how, when my training, basically it's done, first of all, you read about it. You develop an intellectual understanding. There's some beautiful writings. Frieda Fromm-Reichmann is fabulous in this area, and Mabel Blake Cohen have really talked about not only countertransference, but how the role of the helping professional feeds into countertransference. So you can get an intellectual base of it, and then it just becomes a part of your supervision. That it's something that's talked about, where it's introduced. Basically, how does this client make you feel? Do you notice yourself avoiding certain topics that really are kind of central? And that through a kind of careful, fine detailed approach to therapeutic process, and even the diagnostic process, because I think the same stuff comes up when you're doing diagnostic work, whether you're using interviews or whether you're using tests or things like that. All this stuff comes up. It's not just in psychotherapy proper. By going through and understanding fine-grained detail of this, one can then become, it's kind of like this, where the supervisor's task is to help the beginning therapist to see the defenses that get in his or her way, that look at what kind of feelings make them anxious and what they do to avoid it, and then how are you allow yourself to have the unholy feelings that usually come up when you're working with a client. And I call them unholy because, we're helping professionals. We're supposed to, be kind and caring and that sort of thing. And then you get a client like Jane 1, who I can promise you within a couple of months, you're going to be idealized and then you're going to go into the hurt locker. I mean, it's just going to happen. And then what's it like for you when that happens, where you now are move from the well-regarded, highly valued expert to, did you really think that was a reasonable thing to say? That's about the stupidest thing I've ever heard. Well, that kind of takes a capacity to step back and realize it's not about me. It's about this person, and to be able to help point out that defense as a way that person is having trouble with life. Evaluation as an interpersonal dynamic is one that really destroys the capacity for developing long-term relationships and being able to find an empathic and firm way, bringing well-bounded, firm, empathic way of dealing with that tough defense. You know, that's a defense. It's not the person's just woke up that morning, decided to be a difficult person for you. This is what this person's doing all the time. It's just you. This is a place where you get to kind of look at it and learning how to move beyond the me. That what Sullivan called the me, our most valued possession, which is our tendency to over-personalize, and to step back and to engage in, we're going to be a participant in the situation, but we also want to be an observer, and we want to be able to go back and forth between those two. And so being able to do it, learning to calm ourselves and be able to do that. Is that responsive to, that's how I would see it. Sure.
I think the wonderful thing about countertransference recognition is for not just alone in psychiatry, but in every interaction for students and trainees, it's important to remember, any relationship you have with a patient, if you find out you're not looking forward to this patient, recognize there's something going on. That's actually very powerful, more than any medication or physical thing you're going to do, because it's going to so vitally affect compliance and whether the patient really comes back even. Whether they take the medicine, they throw it down the thing, they OD on it, whatever, all the various meanings of both the relationship, medication, and anything else. And it's one of the things I think from a trainee standpoint in particular, it's important to recognize.
Singing my song. Thank you. That's a good place, I think probably a good place to stop. Thank you.